Hello, good morning. I'm Ashok Rokade, consultant rhinologist and anterior skull base surgeon from Winchester and the University Hospital Southampton, UK. I welcome colleagues from around the world on behalf of organizing team to this inaugural Winter Global Rhinology Endoscopic Sinus and Anterior Skull Base Surgery Webathon. Global Rhinology Network is a registered non-profit organization with a mission to foster surgical education in rhinology and skull base surgery. We have successfully hosted annual multi-center live surgical webcast, The Lioness, since 2014 in collaboration with Lion Foundation. Thousands of surgeons from all corners of the world have benefited from it. More than 2,000 surgeons from 110 countries have registered for GRACE 2020. We will have hugely informative and engaging sessions presented by eminent rhinologists and skull base surgeons from around the world. GRACE 2020 is hosted at the Global Telemedicine Studio of Professor Wilco Groneman in Utrecht in Netherlands. It is supported by Medtronic and Karl Storz. Thank you.
Imagine, what if you could do even more to bring relief to your chronic rhinosinusitis patients with technology customized to your unique clinical and facility needs? Introducing Stealth Station Flex ENT Navigation System, a customizable system from Medtronic ENT, a market leader in image-guided surgery technology, featuring 6 hardware configurations, an optional portable card, 2 different electromagnetic emitter options, with flexibility in hardware design and optional software functionality. Get everything you need and nothing you don't with Stealth Station Flex ENT. Let's flex forward. Contact your Medtronic representative to customize a navigation solution that's right for you.
Now I have the pleasure of introducing Dr. Zara Patel. She's currently the director of the Endoscopic Skull Base Surgery and Associate Professor of Otolaryngology at Stanford University Medical Centre. She completed her residency training at Mount Sinai Medical Centre in New York and fellowship training in Rhinology and Endoscopic Skull Base Surgery at Stanford. Is it Stanford or Emory?
Stanford.
Okay.
Then I went to Emory and then I came back to Stanford.
Stanford, right. I was like, Stanford. Anyway, she's the media past chair of the Education Committee and now a member of the Board of Directors for the American Rhinologic Society. Dr. Patel will be presenting olfactory considerations and functional endoscopic sinus surgery. Thank you, Dr. Patel.
Thank you, Troy, so much. And thank you, Ashok, for having me be part of this. I'm sure it's been a wonderful session. I joined at the very beginning and then I went to sleep and now I'm back in here. So I'm gonna go ahead and share my screen with everybody and get to this. So I'll be talking about, thinking about our sense of smell or the patient's sense of smell when you're performing endoscopic sinus and skull base surgery. And it's a topic certainly near and dear to my heart. I do a lot of research into olfactory loss. I have, in addition to seeing chronic sinusitis patients and performing endoscopic skull base surgery, I have a clinic once a month that I run for solely for olfactory loss patients. And as you all know, with COVID-19, there is now even more of a spotlight on olfactory loss. And so I think that's the silver lining for me, perhaps, of the pandemic, and that there is more attention being paid to this really important sense, and people are having a lot more empathy for those who have lost it. So these are my disclosures, none are relevant. So, really to start thinking about what we're talking about. A lot of people know about the olfactory epithelium. They feel like it's high up in that middle part of the nasal cavity and not really in an area that we usually are operating when we're doing sinus surgery, and so not to worry about it. But it is an area that unfortunately often gets damaged inadvertently when people don't mean to be in that area, but for some reason they do get into that area. And I'll say that, this is a global event, and medical legal issues are not the same everywhere, but certainly here in the United States, one of the most highly litigated areas in all of otolaryngology is in rhinology regarding sinus surgery. And one of the areas that is most highly paid out and rewarded to a plaintiff, meaning the patient, is in areas of olfactory loss after surgery. And the vast majority of the time, this is because the consent did not really cover the possibility of olfactory loss when they were discussing the risks of sinus and skull base surgery. And this is something that I found out probably about a decade ago when someone presented this data medical legally. And ever since then, I've made doubly sure to discuss this possible risk with my patients. Thankfully, with such a focus in this area, I've been lucky enough not to have that, but I certainly see a lot of patients in my clinic who have had surgery elsewhere and then present with loss in this area. So the general idea of where this is a pretty broad range. I've realized when you look at this in the literature, in textbooks, and in publications, when people talk about the olfactory epithelium, they talk about a 2 to 10 square centimeter strip of mucosa on either side of this posterior superior septum. If you think about that range, 2 to 10 is quite a large variation in size, and that's probably based on individual anatomic variability and also on just the fact that people have studied this in different types of cadavers and found differences. And so it just shows you that there is a very broad range, and perhaps some people may have a much larger area that's covered by olfactory epithelium than others. You can see that the superior and middle turbinates and cribriform region are all involved. And the olfactory receptor neurons coalesce into approximately 50 macroscopically distinct bundles called olfactory villi. And that's an area that, if you see here in this endoscopic picture, this is within a septal flap, within a septoplasty. If you go all the way up to the top, you can actually see these little bundles going up through the cribriform. By the time you are at this villi, you've already had all of those tiny microscopic millions of olfactory neurons coalescing. And so certainly that is not where you should start paying attention. That's really the end point where they are all going. And I put this slide up just to show everyone the, again, wide variability. If you just Google an image of olfactory epithelium, you'll see this. So I want you to first look over at this picture. You see this tiny little blue shaded area up at the very top. It's just kind of the very top little ditzel of your septum, maybe going on to your superior turbinate a bit. And you look at it over here on the lateral aspect, and it really only seems to affect that superior turbinate. Same if you come over to this side, it really is only affecting the superior turbinate. Down low, you can see on this picture, it really seems in this anatomic representation to only affect the anterior portion of the middle turbinate in this anatomic specimen. And then finally, when you get down to this lower area, perhaps this is a little bit more realistic, where the nerves are coming down and covering much of the surface of the middle turbinate. Now, I will say there's been a lot of discussion as to is the olfactory epithelium actually covering the middle turbinate surface? And I think this is probably the best data, and it's, again, a histologic study in cadavers, but it's very well done. And what I want you to notice is that this 36% number, this is in the middle turbinate, the posterior portion of that middle turbinate. Almost 40% of their specimen had olfactory epithelium present. You can see the anterior portion didn't really have much, And of course, in the superior turbinate, there was quite a lot, especially posteriorly, but also anteriorly. And so when we think about preserving the olfactory epithelium with whichever surgery we're doing, you really have to think about both the middle and superior turbinates. Now, there is a lot of data out there suggesting that it's totally okay to take the middle turbinate. And I know certainly when I was back in training, and still to this day in some people's ORs, the very first step of their sinus surgery is to remove the middle turbinate to gain access. And even in my OR, if the middle turbinate is very highly degenerated with polyps, I don't feel any qualms about removing that non-functional tissue. But I will say that if you look at this table here, this is probably the best data coming to suggest that it's totally okay to remove the middle turbinate. And this group of authors, Tim Smith and Zach Soler, Peter and Jess, they looked at a prospective group of patients, bilateral middle turbinate resection versus preservation. And a lot of these quality of life type scores were really just the same and no significant difference between. And they actually found an improvement in patients with polyps if the middle turbinate was resected in the smell test. But I will note that in this particular data set, the patients that had their middle turbinates removed started at a much lower score in their smell, and so had a much sort of larger range with which they could improve. And we do know that polypoid degeneration of the middle turbinate, number one, causes decreased functionality of the olfactory epithelium if it's there on the middle turbinate, and removal of polyps from blocking the olfactory cleft, which would be off the head of the middle turbinate, can allow more access of airflow. So I think this is a very specific patient population, and that if you have a normal functional middle turbinate, that's not what you should really be considering. Now, I want you to think about one other thing when you remove turbinates during surgery, which again, I would just caution you not to do if at all possible. This unfortunate patient, you can see, has had both their middle turbinates and inferior turbinates removed. And, you know, regardless of all the other possible symptoms that this patient may eventually suffer from because of this tissue removal, when I'm thinking about how it's going to affect their smell loss, I think about a few different things. Whenever you remove any nasal tissue, whether it's the inferior or middle turbinate, you are altering directionality of that airflow. And so when we have all of our turbinate structures intact, there's a particular airflow that directs the air to the olfactory cleft. That's what makes it most easy for the airflow to reach that area. And so once you start removing this tissue, it is much less likely that airflow is going to be able to be directed up towards that area. It's much more likely to go straight back into the nasopharynx. The other thing is that as you remove tissue whose main job is to humidify the nasal environment, which turbinates do, you have to keep in mind that we cannot detect olfactory molecules until they dissolve into the mucus layer of our nose, and then they can bind with our olfactory receptor neurons. And so the more dry you make the nasal environment, the less likely that patient is to be able to detect olfactory molecules in their environment, even if they have a completely wide open olfactory cleft and all the olfactory epithelium's still intact. And so really any procedure that's going to create more dryness is going to create problems for smell. And then of course, as I just sort of showed you, there probably is going to be loss of some amount of the olfactory epithelium. And we really don't know because of this high variability between individuals. We also don't know that in some individuals, we know that they definitely have a dominance of smell. One side is what they depend on more for their olfactory sense. And so if you remove, say, the middle turbinate on the left-hand side of a patient who happens to have a large amount of olfactory epithelium on the middle turbinate and happens to be left-sided dominant in their sense of smell, they're going to be much more sensitive to that removal than someone who has less olfactory epithelium on that turbinate and less dominance. And so because we currently don't test for this and we don't really have a good way of knowing how much olfactory epithelium is on these structures, preservation is what I would recommend. So the next thing to sort of think about when we operate, especially in polyp patients, is those polyps that are within the olfactory cleft. And a lot of people will ask me, well, how do you know how much to remove? You know, are you worried about removing the olfactory epithelium when you're removing polyps? Should you just leave that area alone? And I would say, no, don't leave it alone, but certainly be cautious in the way that, in which you're removing the polyps in this area. And I'm just playing this short little clip to show that when I'm removing polyps in the olfactory cleft, it's not just a mowing down without pausing and looking. There's a little nibble and then a look, a little more nibbling and then I look, and you really are palpating the entire time with your debrider as you're doing this to make sure that you're really not wanting to strip this area. Certainly there's not just olfactory epithelium, but the possibility of creating a CSF leak in that area, but you do want to bring it almost all the way back to just a thin, normal mucosal surface. So moving on, let's start talking about frontal sinus surgery. Operating in the frontal sinus, especially as we start doing extended approaches to the frontal sinus, is another main area where I see patients coming to my clinic who have had surgery elsewhere and then are left with olfactory loss. Draft 2Bs and draft 3s, unfortunately, in the wrong hands are quite commonly the reason why patients are left with a decrease in smell. And I want you to just look at this anatomic picture and you can very easily see why. You can look at the frontal sinus and you can see that the actual onset of the posterior table is even just slightly posterior to where the cribriform plate can advance to. And the little tiny holes that allow that olfactory fillet to go up and down through the cribriform actually goes even more anterior than that posterior table beginning is. And so you really need to keep this in mind when you're doing a draft 2B or a draft 3, when you're connecting these sinuses together, that, you know, a lot of people will say, use that first olfactory fillet as your posterior border of a draft 3. And I would say, if you are doing that, it's too late. You've already bagged a large amount of microscopic olfactory epithelium as you've approached that olfactory fillet. So this is just an example of a draft 2B that I want you to see. When I do a draft 2B, I don't remove the entire middle turbinate in my approach. I'm simply separating the middle turbinate from any lateralization that's occurred from their prior surgery they had. And then I'm just removing the very top part of that middle turbinate, approaching the posterior table. Here you can see I'm really sliding my through cut all the way up to the top and then just drilling. You can see at the bottom of this picture that the middle turbinate, the whole entire mid to posterior inferior range of the middle turbinate is completely intact in this surgery. And so you really don't need to completely remove that turbinate when you're doing this approach. And I would really strongly advise that you don't. So here's an example of a draft 3, and it's the same sort of picture. Here's the normal side you can see of a frontal sinus, and then when you go to the other side, you can see this is the reason we're doing the draft 3. It's completely socked in and a lot of mucosal pockets and pus on this side. And even in this case, I'm just removing that very top part. You can see at the bottom of the screen, the rest of that middle turbinate remains intact. And I'm taking great care as I begin drilling into this area. You can see in the midline is that part of my cribriform where the olfactory epithelium is, where the skull base is. And as you see me continuing to drill up into this area, I want you to notice that I'm taking great care to really put all pressure anteriorly as I'm operating. I'm taking great care not to push on that olfactory epithelium, not to push on that cribriform at all. You do have to continue operating all the way up to the very top of your sinus when you're doing a draft 3, because as you've seen as we're going through this video, these pockets of pus that can become sequestered away from the rest of the frontal sinus cavity, you need to continue to operate until you've really connected that entirely with the rest of your frontal sinus cavity. But even as you're going into these very narrow areas up top, I'm really taking great care to avoid this area in the middle, in the midline and posteriorly. And here you can see at the very end, as I'm placing my steroid-eluting stent, you can see quite a large proud mound of olfactory epithelium and cribriform plate that I have managed to not touch at all. And these patients heal very nicely without any loss of smell and no risk of CSF leak. So that's how I would recommend you doing your draft 3. Now, certainly even when you are operating to remove a tiny, small little structure, you can see here's a tiny little melanoma that is at the very posterior aspect of the septum. It's not high up. It's not within the olfactory cleft itself. It's just above the sphenoid sinus. And you can see that even in this area, you can risk losing smell if you try to use too large of a piece of tissue to cover this tiny little defect that's been created. And so I would just recommend that if you have small defects that you're trying to repair in sinus and skull base surgery, that you use the smallest little mucosal graft that's going to appropriately cover that area, because now you can see I've really preserved as much olfactory epithelium as possible. I haven't had to harvest a septal flap. I haven't had to sacrifice a lot of that olfactory epithelium either by harvest or by covering it with a graft. And so I would really encourage everyone to do that as well. And then finally, if we're considering where the areas are in skull base surgery, I'm just going to show you a traditional pituitary approach that I had recorded for the ARS some years back. And there are many areas that you can possibly damage the olfactory epithelium in this type of approach and repair. And so I'm just going to skip through this briefly. As you're doing the approach, when you're doing your posterior septectomy incision, I want you to notice that it is completely in line with the ostium that I'm making that cut. And I'm not actually extending this any further superiorly. I'm just cutting straight back from this to the ostium itself. And then when I start to remove tissue to form my septectomy, it's really all just down. I'm only barely removing any tissue superiorly. And you don't need that. Even in tumors that go up suprasellar, even in procedures where you need to take the planum, you do not need to take your septum. You just need to take the septation once you're within the sphenoid sinus all the way to the roof to access these areas. And so you really should completely preserve the septum as you're moving back superior to the ostium itself. So I'm just going to skip forward to the reconstruction part of this procedure. And once you're starting to raise a septal flap, if you need that for reconstruction, I want you to again be thinking about where your olfactory epithelium is when you make the superior cut of the nasal septal flap. You definitely want to make sure that you're preserving that strip of olfactory epithelium as you're coming forward. And not only are you preserving that, but of course you're again making sure that you don't inadvertently create some leaks. So I want you to notice that only after you've reached your middle turbinate do you start coming straight forward. Otherwise, you're just at the level of your ostium, then you come up, and then you can proceed. So that's, in short, the ways in which you can protect your olfactory senses as you're operating, both in endoscopic sinus and skull base surgery. This is my Instagram and Twitter. I'm mostly on Instagram, just a touch on Twitter. So if you guys want to follow me or ask me any questions, but certainly we have time for questions now. So I'll stop sharing and throw it back to you, Troy and Ashok.
Stealth Station ENT, the advanced image guidance system for the full range of navigated ENT procedures. Engineered with you in mind, based on decades of scientific, clinical, and engineering expertise, we're expanding what was previously possible with image-guided surgery. Flexible and elegantly designed, Stealth Station ENT streamlines the workflow so you can maintain focus. The flat, under-the-head emitter allows for an efficient setup. Its design allows for a large EM field. Easily find your patient's exam through a variety of network options, super speed USB, or optical disc. The visualization and modeling features give you the perspective you need. Leverage data from multiple sources to create high-resolution 3D images. View structures and pathology with high fidelity. Registration expertly matches the three-dimensional positioning of the patient with the preoperative images used for navigation. Patient registration combines registration methods and provides numerical and visual accuracy feedback. Leverage the latest technology for advanced surgeries. See more, do more. The result? You have an image-guided perspective like never before. With Stealth Station ENT, you're at the forefront of ENT surgery. You are Stealth.
Okay, thank you, Dr. Patel. So I know you are holding up a case for us, so we appreciate that. And so we have a few questions to ask you, though, okay? So if you had mentioned in your diagram that the cribriform actually extends pretty anterior, and so if the first olfactory neuron is not really a good landmark for the posterior table, what do you really recommend then? That people kind of use?
I actually use the posterior table itself as my landmark for the septectomy that I'm making. So to actually do the approach to the frontal sinus and to the draft 3. And then I basically trace a little bit of a curved line because I want to leave a slight mound like you saw. So I trace a tiny curved line in my mind or with my caudal or Freer or whatever it is that you're using to make your septectomy from that posterior table to where you've drawn your incision points. A slightly arched line instead of a straight line, and then you can make sure that you're definitely preserving all olfactory epithelium and you're preserving your cribriform very nicely. And people think that they need to make that straight approach in order to have good access to the entire frontal sinus. And I have not found that to be the case at all, because you have so much anterior room that you can create for yourself, even in patients with a very small natural AP diameter. Those patients are just going to have more frontal beak for you to go through. And now that we have our high-powered, 30K speed, high-powered drills, that's really not a problem and not an issue. You just take more anteriorly and you have more than enough working room.
Okay. So the question is, what is the reason for the loss of smell in the patient that the operation was only done on one side of the nose?
Yeah, so that goes back to what I mentioned at the very beginning, in that patients, not everyone, but certainly some patients do have a dominant side of what they're using for their sense of smell. Sometimes that seems to correlate with nasal anatomy, not always, but sometimes, if someone has a big septal deviation that they've had their entire lives, and the airflow has not been as much going towards the olfactory epithelium on one side versus the other, perhaps they may be dominant on the other side. This is, again, not always the case, but in some patients you can see this. And it's probably one of these use it or lose it phenomena that happens in the entire rest of our nervous system, and that the nerves that have been utilized most throughout our lifetimes are the nerves that are going to be the most robust and ability to pick up on senses the most robust. There's also the fact that, we regenerate nerve and olfactory epithelium throughout our lifetimes. The olfactory nerve is unique in all the other cranial nerves in that it has this inherent regenerative ability. And so if we have suffered from colds or viruses, even before the COVID-19 pandemic, of course, we've had post-viral loss, and our olfactory system has been able to bounce back, it may have bounced back more robustly on one side versus the other based on, what happened in that area. And so there are many reasons why people can end up with a dominant side, and we don't know what that is before we're going into most of our sinus surgeries. And so if someone is taking tissue, they really have no idea how much of that individual patient's olfactory epithelium and ability to smell they are removing before they do it.
Have you ever encountered patients where that those nerves were removed surgically and they come to you and they lost it, and then over a period of time, though, they sort of gain a sense of smell back? Like maybe those nerves, the other nerves kind of got better? Is that possible?
Pick up on it. So I would say, unfortunately, when you see a patient who's had as much tissue removed as like that scan I showed, that doesn't really happen. They don't get it back. But I will say that patients who have just had damage to an area. So for example, I've seen patients referred to our center who are referred for, like, perhaps they had a CSF leak created at an outside area, and they've been referred in for us to repair that. And as part of that damage, as someone was going through the cribiform or just next to it in that lamella of the ethmoid in the skull base, they created a large swath of damage in their wake in that olfactory epithelium, but it's not completely removed. I have seen patients recover from that. I have seen patients be able to bounce back, and that's probably because there are so many multiple layers of olfactory neurons. Remember, there are millions and millions of olfactory neurons in that tiny little swath of mucosa. And so, although our olfactory systems are sensitive and vulnerable to damage, they also have a robust regenerative capability. And so unless you're completely removing it, or in cases of trauma, completely resecting it, or in cases of tumor where you have to completely remove that area, people do have some reservoir that they can bounce back from.
Okay. If you have time for one last question,
Sure.
Your regimen for treatment for COVID-related hyposmia.
Yeah, so this is a topic that's definitely hot and in the presses these days. And it's basically the same thing that I do for all other post-viral anosmia, and that is step one. You have to do a good exam and make sure that there is no residual inflammation within the olfactory cleft or nasal cavity, because we know that olfactory nerves will not regenerate well, and they will not create the correct connections if there is residual inflammation in that area. And so, based on a study, a randomized controlled trial that I did a couple years back, where I added budesonide rinses to olfactory training, I realized that even in cases where we don't macroscopically see inflammation, some of these patients still have microscopic inflammation, because if you add budesonide to their regimen, they have a significant improvement beyond what olfactory training itself can give. So step one, evaluate and decide whether or not you think someone needs budesonide irrigations. That's a topical steroid irrigation for those of you in other countries. And then step two, olfactory training. So olfactory training, for those of you who don't know, is just a very simple, structured smelling protocol. It's, again, has very high level randomized controlled trial evidence that shows that it can help people after loss for multiple different etiologies, but certainly post-viral is one. And this combination of olfactory training and budesonide irrigations is often what I use. Ever since I performed a study looking at the use of omega-3 in post-surgical endoscopic skull base surgery patients, I have also sort of talked to my post-viral and other etiology olfactory loss patients about the findings in that study, that omega-3 had a significant improvement in the number of patients who had loss of smell after that surgery. And the fact that it would definitely be an extrapolation to apply it to this patient group because it was a totally separate patient group. But, there is such little downside to omega-3 and such robust basic science evidence that it can be helpful in nerve regeneration, and not just this area, but multiple parts of the body, in the brain, in the spinal cord, peripheral nerve injury, so many different areas it's been studied in, that I feel quite comfortable suggesting that my patients try this as well.
All right. Well, thank you for your time, and thank you for the very insightful lecture. We really appreciate it.
No problem. Thank you so much for having me. I'll see you guys again tomorrow.